Next we are going to discuss is megaloblastic anemia. So remember, these megaloblastic anemia, they are primarily caused by impaired DNA synthesis. So the megaloblastic anemia, they are primarily caused by impaired DNA synthesis in hemopoietic precursor cells that are in bone marrow. So remember, there are large immature red blood precursors that are known as megaloblast. So these large immature red blood cells precursors, they are characterized by delayed nuclear maturation. So the main cause of megaloblastic anemia is impaired DNA synthesis due to the deficiency of vitamin B12 or due to the deficiency of folic acid. Remember, vitamin B12, it acts as a cofactor for enzymes that are involved in DNA synthesis. So deficiency can occur due to insufficient dietary intake, and it is especially seen in vegetarian people. Or there could be malabsorption like pernicious anemia or other effect or other causes. Now the folic acid, this folic acid, remember, it is essential for nucleotide synthesis in the DNA. So deficiency can result from inadequate dietary intake, especially in the malnourished individual and in alcoholism patient. So the less common cause of impaired DNA synthesis leading to megaloblastic anemia include genetic disorder that affect the vitamin B12 or folate metabolism. Remember that absorption of vitamin B12 from the dietary source primarily occur in the ileum and require intrinsic factor that is secreted by the gastric parietal cells. Now the vitamin B12, remember vitamin B12, it is transported bound to transcobalamin. 2 in the blood, and it is taken up by cells for use in various metabolic pathways. Similarly, folic acid, it is derived from dietary sources like leafy vegetables and cereals. Folate, remember the folate, it is converted into tetrahydrofolate that involves a series of enzyme-like reactions. The active folate derivative, they are essential for synthesis of purine and thymidine that are precursor of DNA. Now vitamin B12, administration of vitamin B12 supplements can be given either orally or intramuscularly depending upon the severity and cause of deficiency. Similarly, oral supplement with folic acid can be given. The dietary source of vitamin B12, they are limited to animal derived foods like the liver, kidney, meat, fish, eggs, cheese and the milk. So vitamin B12 absorption involves several steps. Remember, in the stomach, vitamin B12, it forms a stable complex with heptocorrin, that is a glycoprotein that is found in saliva, gastric juice, bile and other secretions. In the duodenum, the pancreatic enzymes digest this heptocorrin, releasing vitamin B12. The B12 then binds to the intrinsic factor that is a glycoprotein. This glycoprotein is secreted by the parietal cells of the stomach. So vitamin B12 then binds to intrinsic factor. So this complex that will travel to the terminal ileum, where it binds to specific receptor of the mucosal brush border, facilitating the absorption in the mucosal cells. Now within the ileal mucosal cells, vitamin B12 is relieved from intrinsic factor, and it binds to the transcobalamin, to a transport protein. So this complex is transported via the portal circulation to the liver, bone marrow, and the other tissue. So liver, remember, it is the primary storage site, storing about 2 milligram of this vitamin B12. Additional stores in kidney, heart, and brain. The vitamin B12, it is excreted by the bile. So in deficiency in this vitamin B12 can lead to megaloblastic anemia. Apart from that, one you can see is neurological complication like peripheral neuropathy. The cause of deficiency that could be due to inadequate dietary intake, malabsorption syndrome like pernicious anemia, or certain medications that affect the absorption. Now the folate, remember, it is also known as folic acid or turboglutamic acid. It is a water-soluble B complex vitamin, and in nature it exists as a polyglutamate form that must be converted into dihydrofolate and tetrahydrofolate in order to be metabolic active. Now what are the source of folic acid? Remember, the main dietary source there include the fresh greeny leafy vegetables, spinach, broccoli, fruits, livers, kidney. The folate, remember, it is primarily absorbed in the duodenum and upper jejunum. In the mucal cell of intestine, these polyglutamate, they are converted into monoglutamate. So the mono and diglutamate, they are further reduced to tetrahydrofolate. See, this tetrahydrofolate, it circulates in the plasma as a methylated compound, and it is transported into cells by the carrier proteins. Remember, liver and red blood cells, they are the main storage site for folate. Primarily they are stored as methyl tetrahydrofolate polyglutamate, and total store are about 10 to 12 milligram. The folate, remember, it is excreted in sweat, saliva, urine, and feces. It acts as a coenzyme. Important is it acts as a coenzyme in important biochemical reaction, including the transfer of one carbon unit. Apart from that, it plays a key reaction role in thymidine synthetase reaction, in a homocysteine methionine reaction. So folate deficiency results in impaired DNA synthesis due to reduced availability of coenzyme tetrahydrofolate. Vitamin B12 deficiency can indirectly cause the folate deficiency by trapping folate as methyl tetrahydrofolate. Drugs that interfere with the folate metabolism are methotrexate. Remember these drugs, methotrexate and pyrimethamine, that inhibit dihydrofolate reductase and lead to impaired DNA synthesis. Now, what are the clinical features of megaloblastic anemia? You will see it is characterized by large red blood cells that are macrocytosis with abnormal nuclear cytoplasmic. So these you will see macrocytic large blood cells. Apart from that, you will see glossitis. The patient presents with smooth, beefy red tongue. That occurs due to the atrophy of, remember, filiform papillae. Apart from that, you would see is the neurological manifestation associated with, there would be neurological complications like degeneration of spinal cord as well as peripheral neuropathy. Symptoms one could see is numbness, tingling, weakness, ataxia, diminished reflexes that could be seen. Other symptoms are mild jaundice could be seen, angular stomatitis, purpura. Now, coming to the laboratory findings in the megaloblastic anemia, you would see is the hemoglobin is typically low. You would see is a macrocytosis, elevated MCV, anisocytosis, pyclocytosis. The reticulocyte count is low to normal, that reflects ineffective erythropoiesis. Apart from that, you would see is hypersegmented neutrophils. That means there are more than 5 nuclear lobes. So there would be increased iron in on bone marrow findings. You would see marrow cellularity, hypercellular marrow, increased iron in erythroid precursors. The biochemical findings that you would see is there the serum unconjugated bilirubin, its increased LDH is increased. Serum iron and ferritin, they may be normal or elevated due to the excess iron in the storage form. So a blood test can be diagnostic, including CBC, peripheral blood smear, reticulocytes count. Bone marrow examination could be diagnostic, revealing the hypercellularity with megaloblastic changes in the erythroid precursors. The biochemical test that used to differentiate between vitamin B12 and folate deficiency, that can be. What are the tests for vitamin B12 deficiency? You can do is vitamin B12 assay, microorganisms like Eugenella, lactobacillus. They are used to assess the vitamin B12 levels. Apart from that, you can do is Schilling test. So remember Schilling test, that is a 24-hour urinary excretion test. It is positive in the case of megaloblastic anemia. Apart from that, you can do is serum enzyme levels like elevated in vitamin B12. You would see is methyl malonic acid and homocysteine level, they may be raised. The treatment for megaloblastic anemia we can give is vitamin therapy. Hydroxycobalamin that can be given, it can be given by an intramuscular injection, a dosage of 1000 microgram for 3 weeks that can be given. Folic acid could be given, that can be given orally. The dosage is 5 milligram tablet for 4 months. Apart from that, blood transfusion can be given, but they are generally avoided due to risk of circulatory overload. Pernicious anemia. It is also known as, remember, Addisonian Megaloblastic anemia, and it is common in individual of North European and African American. So the atrophy of the gastric mucosa leads to absence or low level of the intrinsic factor that is caused by autoimmune reaction against the gastric parietal cells. So that would destroy the parietal cells. So remember here, the antrum will be spared. It affects the gastric and pepsin secreting portion of the stomach.